I didn't know anything about prostate cancer, and my father had it 7 years ago.
Yeah.
So
That's not, and the thing about it is that's not uncommon.
you're right.
It's not uncommon that happens. Is that I think the population is a little better informed, but it's gone through a lot of iterations because PSA came out in the late 1980s, early 1990s. There's a big push, and then you got kind of bantered around that we're making too many diagnoses, we're over treating people. Then it got pushed on the back burner, and now we're realizing that some of the men we didn't screen, which we should have screened, are now presenting in their mid to late 70s with metastatic disease, and so it's a mess. It really is a mess. It's been a mess for 30 years.
Wow, that's scary. But let me formally introduce Dr. Colberg here. Dr. Colberg knows my case intimately, everybody, because he was a surgeon that, believe it or not, Doc, it'll be 1 year on May 14th. I know you do a lot of these, but it's already been almost 1 year. May 14th, 2020, I had they call radical prostatectomy. Is that right?
Yeah, a robotic prostatectomy, yes.
Right. So that was almost a year ago. And so far, my PSA levels are all coming back really well. And the doctor seems happy. So if he's happy, I'm happy. But the Dr. Colberg is from the Yale School of Medicine. He's actually a professor of urology at Yale, and he is the director of the urologic oncology department there. And as I said, he also is my surgeon, so he has a very special place in my heart. And I thought that it'd be really helpful if we got together today and just talk generally about cancer and prostate cancer in particular, because as I said, about not even 10 years ago, my father had prostate cancer and he was maybe 72. And I thought, well, that's what old guys do. Old guys get prostate cancer and they get it taken care of, right? And then, holy cow, whatever, 7, 8 years later, I just by accident discovered that I had PSA levels, and then one thing led to another. And as we said, there's my robotic surgery. So Dr. Colberg tells me that the lack of knowledge about prostate cancer is another sort of epidemic, if you will. Is that right, doctor?
Yes. So like I said, I mean, most men that are diagnosed with prostate cancer have no symptoms. They don't have, they may have urinary symptoms because of an enlarged prostate gland, but they don't have any specific symptoms related to prostate cancer. Most men are diagnosed because their primary care doctor gets a PSA level. They may have a family history of prostate cancer. They get a PSA level, or someone does a rectal exam and occasionally feel a lump or bump in the prostate gland. So the PSA has been a blood test that around since 1990, 1989. It measures a protein in the blood system. It's only made by the prostate gland. So, and just because you have an elevated PSA level doesn't mean you have cancer.
Right. Well, let me ask you about that because, guys, unfortunately, we have to go to our PCP and maybe even get referred to a specialist, and we call it Dr. Jellyfinger. You got to go see the doctor and get the digital exam. And for me, there was no enlargement. There was nothing. There was no signs or symptoms, as you're saying. The only reason that I got the test was because I switched doctors and she wanted to have a baseline of what my blood test was. So as you said, that just so happened to be the reason that I found out. And I'll be honest with you, I feel really lucky and fortunate. I want to get to that in a second, but can you just really quickly tell us what the prostate is and what it does?
Yeah. So prostate is a gland that sits below the bladder. It functions in two ways. It makes up part of the urinary tract. So actually, when you go to the bathroom or urinate, you urinate right through the middle of the prostate gland. So it makes up a short segment of the urethra. The other function it functions as a secondary sexual organ, so that when men ejaculate, the majority of the fluid that comes out with ejaculate comes from the prostate and seminal vesicles, which are attached to the prostate. And they provide the nutrients so that the sperm can live in the ejaculate. So two functions, part of the urethra and part of a secondary sex organ.
And it's like a little acorn size thing, right?
Well, it depends. I mean, an average size prostate gland is, 30, 40 grams. Sometimes it can get really large into 100 grams, but usually that's not from cancer. That's from benign disease that makes it get really big.
And as it gets larger, or as we age, and that urinary tract functionality of it is one of the reasons that we see men having to go pee a lot more and whatnot. Is that correct?
So typically with benign non-cancer disease, the enlargement occurs around the urethra tube. And so that men start getting up more frequently at night. Their stream may be slower. They may go frequently during the daytime. They may have some urgency. They may feel like they're not emptying their bladder. And all those symptoms, those are symptoms of an enlarged prostate gland, not from prostate cancer. I mean, they can happen in the same group of men. Prostate cancer typically forms in the back of the prostate gland as opposed to the middle of the prostate gland. Although, again, you can have it in both places.
Gotcha. Well, and for me, like I said, after I got the PSA levels that were higher, I started to notice that I was going to the bathroom a lot. It wasn't until after I started paying attention to it that I even noticed. So I'm sure that's the case with lots of guys. What's the impact of prostate cancer in men?
Well, I mean, so that's changed a little bit. So when PSA first came out, we made a lot of diagnoses of prostate cancer, and we treated just about everybody, no matter what parameters they had on the biopsy. The last 5 to 10 years, we've been a little bit more selective as far as treatment. And that's based on what the biopsies show when you make the diagnosis. So when someone has an elevated PSA level or abnormality on their exam, we recommend doing a biopsy.
What I was getting at is the number, like prostate cancer is the number 2 cancer killer of men.
Well, it's the most common cancer diagnosed in men.
Okay.
I haven't seen the most recent data, but it's somewhere around 200,000 men a year diagnosed. As far as the people who die from it, it's somewhere between 25 and 30,000 men die a year of prostate cancer. So it hasn't changed significantly. And usually the men are older, not always. And the question is, by making the diagnosis early, are we impacting the survival of men? We probably are. The data suggests that we are, with the screening that's been going on for now 30 to 30 years.
Yeah, and that's kind of ultimately my question here today is exactly that, around screening and whatnot. And I've also been told or read, or I think I've been told, that many men die with prostate cancer without ever knowing that they had it. The number is something like 60%. It's a very high number.
So there are 3 risk factors of developing prostate cancer. One is age. The older you are, the greater chance you'll have prostate cancer. So if you take 80, 90-year-old men and was able to take their prostates out or biopsy their prostate, you may find prostate cancer in 65, 70% of those men. And they may never be bothered in their lifetime from it.
Mm-hmm.
The second risk factor is race. We know that African-American men have a higher incidence of prostate cancer, tends to be more aggressive. And thirdly is family history. If you have 1 or 2 first-degree relatives, your risk of developing prostate cancer is much greater than the normal population. Now you're a little bit, you specifically, your father was younger, but if you have your father's 95 years old, you're probably not, and has prostate cancer, you're probably not at a higher risk. But if your father was 60 years old and had prostate cancer, and his brother had prostate cancer at 55, then you're probably at a significantly higher risk of developing prostate cancer.
Yeah, I already told my son, who's 18, I already told him that he's got to start being aware of it.
and that kind of dovetails into who should be screened and how should we
Right.
screen, and that's gone through a lot of iterations. Now there was a U.S. government task force that said that we shouldn't screen anybody. This is about 10, 12 years ago, because
Why?
because they looked at the data, and the data's, the problem is there's not a lot of prospective randomized studies. But they show that there is no level 1 evidence that screening early diagnosis made any difference in outcome. Well, they backed off on that. Now that we've decided that we should screen men starting the age 50, younger if you have a family history or African American, and 70. Now, as you know, when you have men that are 70 or really healthy at 71, it's hard to just turn off the screening process and say, "Low, you don't need any more PSA levels."
Right.
So we do tend to get PSA levels on men who are older 70, but those are the guidelines that the AUA has. And then,
to me, I mean, does that jibe with your thought about that prostate cancer? I mean, I know it's a very slow growing cancer, and I got to believe that, if I was to the point at 50 where I needed surgery, and you and my primary and the urologist that referred me to you basically said, we're not waiting, this is something we need to address now. I got to believe that it had been growing there for years.
And you can look at autopsies. Autopsies have been done for other reasons, trauma, and they could find changes in the prostate in men in their 30s. And I've seen prostate cancer men in their early 40s. So again, it's such a heterogeneous disease. It depends on what the biopsies look like. So there's a lot of things that we don't know goes into how aggressive or how non-aggressive it is. So nowadays there's a lot of men we don't treat. They may have cancer, but we don't treat them. And you can see that the number of treatments we've done with surgery is probably down 30%, because we don't usually treat certain men with prostate cancer.
Well, when my father had it, he was never even given the choice of having the radical robotic prostatectomy or the removal at all. He was just given the radiation therapy for it.
Yeah, and again, we don't know. We think we know. People think people have strong opinions, but we don't know exactly what the best treatment is for each individual person. And we tend to operate on younger, healthier men. We tend to radiate older, sicker men. And that's what it's always kind of been. Now, there's some men that just don't want the risk of the surgery, which is incontinence and impotence. There's some men that don't want anything to do with radiation therapy. So it's really a mixed bag now. Nowadays, there's some people think that you don't have to, radiate the whole gland. You need to just treat part of the prostate, something called focal therapy. So, and there's genetic studies we do on the slides now to give us an idea who's more aggressive and not. So every 6 months to a year to 2 years, there's another piece of the puzzle that gets placed.
Right. I don't envy you for having to read all those medical manuals and keep up with all this stuff.
It's kind of a moving target. And the thing about it is PSA has been around a long time, but we haven't really moved beyond PSA. We haven't really gotten a better blood sample, a better way to determine who's going to get in trouble and who's not going to get in trouble.
And the PSA test is sort of the go-to test. And I spoke to some lab people who basically told me that the test is very cheap. It does not cost a lot of money for them to, put the blood on the thing and test it and see what there is. So I guess I just keep going back to the question that you raised, and then I will continue to raise is, why don't they just test? Is there a fear, as you said, that people are going to be overdiagnosed?
I think what happens is that you may be diagnosing men you're putting a lot of people through unnecessary studies like biopsies, MRI. It's expensive. And certainly men who may not need to be treated. Because once you kind of make the diagnosis of prostate cancer, and let's say it's a low risk disease, it's hard to kind of tell the patient, oh, you don't need treatment, and we'll just follow this, and don't worry about it. So once you kind of go down the path, it's hard to kind of stop and turn around and say, well, I'm not going to do this. But that gets into the point when you talk to men with an elevated PSA, they say, listen, these are the possibilities. These are what we have to do. And not everybody will need to be treated if they have cancer. But even still,
from my perspective, getting to your point, once I knew that I had it, if I'm the kind of guy that freaks out, I want it out. And even if my levels were lower than they were, I still would have said, please, please, please. It's like when you get a cavity, right? And the dentist says, we're going to watch that for a year or whatever.
Yeah, and I think at 50, it's a little different conversation. But if you were 70 and you had 1 or 2 cores of prostate cancer, and it was only a Gleason 6, and your PSA was 4.5, and you in a normal exam, and you're retired and living the life great, and so I think again, you got to try to individualize the process. It's not a cookbook or cookie cutter where you look up and say, okay, PSA 4.2, you do this, this, and this. You have to kind of, a lot of patients, a lot of men can tolerate or can understand, listen, I'm fine with observation and surveillance, and I'll come back every 6 months, get a blood sample, and get repeat biopsies down the years. A lot of men don't want to do that. They say, listen, I want it out. I want it taken care of. Every morning I wake up, I have this ache and pain, and I think it's my prostate cancer. So, but the problem is that over the years, by doing lots and lots of surgery and radiation therapy, a lot of men have had their lives changed significantly, whether they're incontinent, wearing diapers, whether they lose their erections. And I think that it's not one size fits all.
No, and I think that men typically tend to not want to take care of themselves the way they should to begin with. And this is just one of those things that's just an added. So I understand it from that perspective, but that's just not me. If I knew I had it, I just couldn't deal with having it, knowing it. It's just not how I am. But I also wanted to ask you about the state of other tests, because there are urine tests now and there are saliva tests now. I mean, the PSA blood work is easy enough, but there's also the availability of urine tests, and I know there's a swab.
Yes. So there are a couple of things. So I think all of them are trying to identify men who need to go on with further workup.
Right.
So that not all elevated PSLs need to have a biopsy or an MRI or whatever. So there's a couple of more blood tests you can do. One is called a 4K test, and one is called what's the other one? It's called PHI, or Prostatic Health Index, where it tries to, by combining different analysis in one test, to try to stratify who's at a higher risk. For example, they'll put it on a scale, and maybe you when someone comes in with a PSA of 5 or 6, and you don't want to do you don't know if you should do a biopsy or not. Maybe you get a blood sample, a 4K test or PHI, and it stratifies low risk, medium risk, high risk, and you decide from then whether you're going to do a biopsy. Some of the urine tests were kind of older tests, PCA3, where you do an examination of the prostate, vigorous rectal examination, you urinate into a sample, you send it away. Again, it gives us this stratification of who you should work on. But nothing's going to tell you have cancer without doing a biopsy.
The biopsy is, unfortunately, that's the ultimate,
Right. The question is, are there some studies we can do to limit or target the men that really need biopsies and ones maybe don't need a biopsy. But again, there's holes in all these studies. They're
Right.
not 100%.
Have you heard anything about the saliva test?
Yeah, I mean, the only time we use saliva, I mean, I'm unfamiliar is that we sometimes do a saliva test to make sure that if we do the biopsy, we line them up together to make sure that those biopsy slides are from that patient, and we have a saliva test that confirm that.
Okay, so basically the saliva and urine, if used at all, they're more or less used to categorize the type of cancer that's been identified on some level.
So stratification. Who needs to get work? Who needs a more thorough workup like an MRI and a biopsy?
Got it. And one question that's haunting me, and we're really concerned with a PSA check, and you touched on it before. Why is the minority population so overrepresented in terms of prostate cancer? Do we have theories on that? I mean, is it socioeconomic? Is it?
Well, people, people looked at that and looked at, like zip codes to determine.
Yeah.
Is it because of the access to healthcare versus not access to healthcare? It doesn't appear to be. It appears to be that the disease is more aggressive in African American men, and whether that's thought to be related to testosterone levels, people don't know.
It's just something with the genetic makeup in an African American man that's different and makes them more prone to prostate cancer. It's just
more aggressive prostate cancer.
Wow, it's just amazing.
And even there are other factors like smokers and obese patients tend to have more aggressive cancers too. So it's not as simple as that. There's some genetic components to it, but that makes up the vast minority of patients' genetics.
Right. Well, obviously our role or our mission is to try to get more people aware of what prostate cancer is and try to get them to say, if you're at the right age or if you've got those right factors, the genetics, the race, and the family history, or if you have symptomology, you might want to talk to your doctor about getting tested. And
absolutely,
that's really what we're about. Because as I said, I mean, I've got, let's see, not as many years of postgraduate education as you, but I've got another 6 years after college of education, and I never knew.
Yeah.
So, I'm as guilty as anybody. And at PSA Check, we just want to make sure that we can get the word out and make sure that more people just do right by them. Women are so good now with mammograms and whatnot. Right. We got to get better at our prostate checks.
We've been trying to do this for years. It's hard.
Yeah, it's very hard
because the messaging is a little mixed.
Well, and that's one thing that I think bugs me is the messaging is mixed, particularly coming out of the CDC and some of the sort of protocols and policies that are set out there.
Yeah, and there's a lot of internal things that a layperson may not know how those policies get made. And a lot of times they're not always made with the guidance from a urologic oncologist, for example, or even a radiation oncologist. They're done by epidemiologists, outcomes people that don't really treat the disease. They just look at the data and the literature and they go with that. And that's fine. But it's more than that sometimes.
Unfortunately, it's like our beloved baseball that's going all to statistics, right? And we're just looking at statistics and not looking at the real
Philly
field.
ball. Philly ball,
Philly ball, yeah. All right, well, doctor, I really appreciate you hopping on with me for 40 minutes.